So it's great to be back again. The talk today, I think, is very pertinent as diabetes continues to rise, not just in the United States, but worldwide. So in the past 15 years ago or so, it's gone up by about 20%, so an incredible increase over time. And so I can't attest to there being a child with diabetes in every single school, but certainly they're spread out, our kids are spread out across the state. And so I have, unfortunately, no pertinent conflicts. I will talk about labeled products during the general diabetes management discussion, as children and families typically will talk about products by their brand name, and so I thought it was valuable to give both. And so we'll go a little bit about background and history of diabetes, since I think it's good to have a better understanding of what diabetes really is, and mostly spend our time dealing with type 1 with a couple minutes at the end on type 2. So we'll start with diagnosis and etiology of diabetes. So the little cartoon says, is it the pancreas or the appendix that we don't need? Don't need the appendix, by the way, just there's no test later though. So start with glucose homeostasis. So I'll use my baton here. The islets of Langerhans. And so we have a number of different cells way back in when you were in school, talking about the beta cells, the alpha cells, the delta cells. Well, the beta and the alpha cells are the ones we care about the most when it comes to glucose homeostasis, and because the beta cells produce insulin and the alpha produce glucagon. And so when we think about what happens if the blood sugar increases, what happens is the pancreas responds by producing insulin that stimulates the formation of glycogen, which is basically storage of glucose in the body. So I talk about it as being a little refrigerator inside the body that we open up when we're exercising or when we're not eating for long periods of time, like overnight. That suppresses glucagon production. When the blood sugar is low, insulin gets suppressed and glucagon gets released. And glucagon then opens that little refrigerator, opens those glycogen stores up so that glucose can then be available for the individual. So we know a lot about diabetes. We now know that there is a strong inheritance pattern. However, it's not nearly as strong as type 2 diabetes. So when we talk about type 1 diabetes, we know that there are some environmental triggers mixed in with some type of risk. Either there's protection with certain genes or there's actual an increased risk with certain genes. The end result is you start to get T cell dysregulation. That emits a cascade that eventually leads to the beta cells or the pancreas being damaged through inflammation, and we call that insulitis. And so ultimately we have type 1 diabetes. And why do we care? Because of the long-term micro and macrovascular complications. And so this is not too scary of a slide, but you see the y-axis is the beta cell mass along the left side there, and on the x-axis you have time in the development of diabetes. So as I mentioned, you have some type of triggers in the environment, some immune dysregulation that occurs, and then over a period of time, you have these antibodies produced, which I won't go into details about, but eventually you get to the point where the beta cell mass, there's not enough beta cells to do the job, and the blood sugar rises up, and the child or adult gets diagnosed with diabetes. And so most of us think of, okay, a child or adult with diabetes, we worry about the future. Well, unfortunately, blood sugars influence the now. And so you have very real complications from hypoglycemia and hyperglycemia, particularly if it's prolonged. It can actually be deadly. And so we care very much about trying to maintain a relatively tight range. But what about school performance or athletic performance? And so this slide actually comes from a diabetes sports medicine or a sports medicine on diabetes article, but it talked about the actual influence on cognitive processing, so literally academic performance, as well as what kind of influences a high or low blood sugar has on a child just being able to run around and play and be active and have energy. And so the reality is that if the blood sugar is too low, your cognitive processing drops. The same thing happens with high. And so again, we have to think in terms of trying to maintain that range. So long term, microvascular, that means small blood vessel. Nearly a third of all individuals with diabetes develop retinopathy. Unfortunately, that is one of the most common forms of blindness over time. Nearly half of all renal failure is due to diabetes. And then, of course, the individuals develop neuropathy and limited joint mobility. Macrovascular complications, the risk for heart disease and cerebrovascular disease go up significantly. So relative risk is just, so 1.8 means nearly double the risk of developing a heart problem compared with someone without diabetes, and then stroke 1.5 times the risk compared with someone without diabetes. It's listed as the 7th leading cause of death, but only 1/3 of those with diabetes actually have it on their death certificate, so we all think that every endocrinologist in the country thinks that the actual impact is far greater. So it's all based on, as far as the morbidity, it's all based on what your control is over time and how long is the individual poorly controlled. And so this is risk and then A1C. So hemoglobin A1C, that some very smart scientists quite some time ago figured out that sugar sticks to the hemoglobin of blood cells. And so since blood cells, effectively you could think of them living for about 60 to 90 days, we are able to translate that into an average blood sugar over about 90 days. And so if an individual has an A1C of around 6, that's a blood sugar average of around 120. So 12, not so good. So, we're in the 300s range. And so, for example, here you have an A1C of 12%. The risk for developing retinopathy is 20 times that of an individual who has an A1C of 6. So impacting control is huge then. So notice that lowering the A1C by 1% decreases the risk by about 25%, so big. The problem is that has to be balanced with the risks of variability, so high blood sugars or low blood sugars and changes. Now, when it comes to the diagnosis, the American Diabetes Association uses hemoglobin A1C for adults in the diagnosis, so above 6.5%. That's not yet available for children because the average blood sugars in a child actually change, particularly as they go through the scary time that we all like to forget about, puberty. However, what does hold true for children, fasting blood sugar over 126 milligrams per deciliter, a random glucose over 200 with symptoms, and we'll talk about symptoms here in a moment. Or if you do a fancy oral glucose tolerance challenge where you drink the sugary, nasty stuff and we monitor the blood sugar, if that pops up over 200. And technically you'd have to do it twice, but in general those are the criteria. And that's for all forms of diabetes. So clinical presentation. So we can't think of all of these children and adults as the same, and so the presentation can be quite variable. Those are clones, by the way, anyway. The incidental hyperglycemia is thankfully common, so individuals are picked up through sports physicals. They have Aunt Bessie walks over and says, "Would you like me to prick your finger?" And for some reason the kid says, "Sure." And then through research trial screening, which we do on a national basis, sometimes the individuals have the classic symptoms, and so increased thirst and urination and so on, but they are not ill. And so that is going to happen either the healthcare provider, the family is worried about the symptoms, the teacher picks up on the child going to the bathroom frequently, or brilliant school or public health nurses pick it up. Yes, and we have that every year. We have a nurse pick it up for us. I need to create like a wall of fame, because that's a big deal. And so diabetic ketoacidosis is what happens when it's not picked up early. And there is mortality for children and adults not picked up early enough every year. So we have individuals that don't make it. And so you can see that's a very high percentage of at first diagnosis. So clinical suspicion, increased thirst and drinking, so polydipsia, polyuria, polyphagia, nocturia, so nighttime, getting up in the middle of the night, and bedwetting is a big deal. So we shouldn't see children and adults beyond the age of a few years typically having problems with bedwetting. Yes, it can extend all the way up to 10, 12 years of age, but that's uncommon. So if you have an older child that has that happen, it's a cause for concern. Polyphagia, so they continue to eat, but they still lose weight, is a clear sign. And then if it progresses, they start getting nauseous and so on. Kidney threshold for glucose is the reason for these symptoms. And so the kidneys can only hold on to glucose until the glucose level gets up to about 180 to 200 milligrams per deciliter. Above that, you could think of the glucose as spilling into past the kidneys, and water chases the sugar, so they start peeing more frequently, and therefore they try to keep up because they're getting dehydrated, so they start drinking and all the symptoms ensue. All right, so we'll go in stress and illness. So we talk a lot about ketone production, ketone testing. Why do we do that? Because everyone in this room, we're not going to have to worry about ketones probably today because there's plenty of food back there. But if we go a long time without eating, every one of us will begin to make ketones because it is one of the pathways that we create energy. It's not a very good backup, though. It doesn't give very good, efficient fuel for us, but it's still our backup. In an individual with diabetes, prolonged fasting is not the first thing we think about. We think of, is there available glucose in the body that's just not being used? So the body thinks it's starving. So it's not that they've gone a long time without eating. Their body just doesn't understand that there's energy around to be used. And so ketones are made. So diabetes and stress. So psychological, emotional, and physical stress all will cause the glucose to go up and will cause insulin resistance. So that means you have upper respiratory infection, you have a hot date, you have a math quiz. All of these things will cause the glucose to pop up. And so, as I mentioned, if you do not eat for a long period of time, your body will start releasing those glycogen stores. You can prolong that for a little while, overnight, of course, and then you start to make ketones. The longer it goes, then the higher the risk for problems. All right, so now we'll cruise into management. Is my pace okay? I'm trying to talk fast after hearing that there's actually 8 of us. So we're good. Part of that's caffeine probably too. I shouldn't have hit the coffee so hard. So I like this quote. I put this in here last year too. So there are so many people out there who will tell you that you can't. What you've got to do is turn around and say, watch me. And so it's very important to think of these children. In the past, they were discriminated against. They were held out of school. They were told to transfer to another county. They were set aside and put into special needs classrooms. And so it's very important to understand that we are the ones that support them and make them feel like they're just another kid. What's interesting is that when you think about diabetes, it requires a huge team. And so look at all these groups: diabetes, nutrition education, social services, psychological support, public health services, school support. And then all the way at the bottom, glucose monitoring and insulin management. So without all these other things, the bottom ones don't work. So therapeutic goals for hitting our target. In the past, our targets were much less strict for children and young adults. The reality is we've always been aiming for the lowest possible blood sugars without going too low. And so now the American Diabetes Association has caught up and said, maybe we should actually make the targets realistic for what we want to achieve in everyone. And so you'll notice that it is a little more aggressive for the A1C in adults, but otherwise all of the pre and bedtime blood sugar targets are all the same. All right, going over tools of the trade. So the little cartoon says, I know Sleeping Beauty pricked her finger and went to sleep for 100 years, but she wasn't diabetic. So talking about lens sets and glucose monitoring. This is just an array of glucose monitors. There are literally 5 times this many out in the market across the country. They do have different variations that require a little less blood sugar, or a little less blood, a little more blood. Some of them can be downloaded, some cannot. Some are cheaper than others, offshoot brands and so on. The reality is all of them are pretty accurate, but some of the best brands, or the most common ones we use on the market, we choose deliberately because they do have the best performance metrics. This is, for those of you that have been in the business for a while, this is considered old school now, sadly. And so this is where we used to actually look at the meter, write the blood sugars down on paper. Does everybody remember what paper and pens look like? Now we mostly do uploads, downloads, looking at data. But in the school system, we need a reliable way to be able to keep track of those glucose values, and so very important to write them down on a day-to-day basis, because sometimes the kids have a school meter and then one they use at home and walk around with, and so then when they come to the office, the next thing you know is there's a big gap in the middle during a critical time point. This is an example. Bernard, by the way, is a fake patient, so that's not, there's no HIPAA problem there. But this is an example of what the download might look like from a meter. Many of the children, about 10 years ago, there were a handful of apps. Now there are hundreds of diabetes apps. Most of them are designed for type 2 diabetes, really, but there are quite a few where the families can, instead of remembering what their ratios are, what their calculation formulas are, they can put it into the app, and then all they do is put the grams of carbs and the blood sugar into the app, and it just spits out how many units, which is really fantastic. And so certainly we provide our recommendations to the children and families on what to use. The other one that is very nice, and again, I'm not receiving any funding support from them, but Calorie King is a great one for carb counting to look up grams of carbs. It'd be a helpful one for everyone to just have on your cell phone, because you can, the free version, you can just put in sandwich or bread and apple, et cetera, and it spits out how many grams for you.
What app did you say that was?
Calorie King.
Yeah, but the one before that.
Oh, there are literally
What do you recommend?
dozens. I can, afterwards right, unfortunately there's so many. I have a couple on my phone that I can show you in a little bit, right? So this is a interstitial glucose sensor. You should see more and more children with these on their person. As we continue to advance the technology, these are getting more and more accurate. And in fact, these two versions up here are last year's versions. We now have the upgraded. And so that's Medtronic, and then this one's Dexcom. What they are, they're interstitial glucose sensors that measure sugar under the skin between cells, so that's not blood sugar. It measures it every minute, averages out over every 5 minutes, and transmits that information to either a receiver, which is about yay big, or to the pump, although it doesn't control the pump, or to your cell phone. And so it can go to the child's cell phone, it can go to the parent's cell phone. The parents can be at work, and they can literally be looking at their child's glucose values, which is both very helpful and terrifying, actually. Too little and too much information sometimes. And so this is what a download looks like for what we utilize. This is one of about 25 pages that we put into our EHR. It's a little frightening just looking at that, but it provides very helpful information for trend data. So, you know, one day to the next, you might not be able to really see much in there, but you might notice that every Monday, Wednesday, and Friday that the child spikes up during a certain time, and you can modify their insulin plan to follow suit. So we do a patient-centered approach, and that, frankly, everyone should be doing that. Sub-Q insulin is the mainstay, but thankfully with insurance really opening up, we're starting to have more and more children on insulin infusion pumps, and then some of our families use adjunct agents depending on their other needs. That little cartoon says, "This way we're only being kinda stupid." So, I'm a kid doctor, what do you expect? So you're pretty far away from this. So insulin forms and profiles. This just goes over the variety of insulin formulations that are available. There are actually a few in development right now that should be coming out very soon, and so I could talk about those next year. But the main categories are basal insulin. That's background insulin that you take once or twice per day. It covers you while you're sleeping and in between meals. It kicks in a couple of hours before it starts to rise up. And then you have to give it, as I mentioned, once or twice a day. Most kids once per day. Down at the bottom, you'll see insulin glargine and insulin detamers with the brand names. And those are the most commonly used ones right now in children. And as I mentioned, more will be coming out here shortly. These are the three most common brand names available right now in children as well for fast-acting analog insulins. called prandial right now in this little cartoon. They kick in within minutes, peak in about an hour, and effectively last for about 3 to 4 hours, although it says 5 hours up there. And then the last couple that I wanted to mention, regular insulin, which is the one on the right. That's a little bit slower than the fast analogs. It's the one that we have had for decades. We typically only use it in IVs in the hospital now. And then on the left-hand side, you see NPH. I don't know how many of you remember or are familiar with NPH, but that is an old formulation that you can mix with either regular or one of the fast-acting insulins. And what you end up seeing with that is, we call that a basic injection plan. It was nice because it was oh so simple. And so what you would do is you'd mix it with a fast insulin or mix it with the regular insulin, and you see the peak. So this would go all the way to lunchtime, and then the NPH would be sort of intermediate with not much of a spike early, and then it would peak around lunchtime and then fade. The problem with this insulin plan is it requires the kids to eat roughly at the same time every day, the same number of grams, and have the same level of activity. So how many people, even in here, can pull that off? And so while it was easier, blood sugars were all over creation, and it didn't work very well. And it was also unsafe. In order to achieve really good blood sugar control, you had to really kick up the doses to the point where if you didn't feed the child, they would become severely hypoglycemic during the daytime, and that is absolutely not safe. Our multiple daily injection plan is the most common one you'll see. That's where they take one of those basal insulins, and then during the course of the day, they'll count grams of carbohydrates, check blood sugars, and dose their fast insulin accordingly, and so they'll end up taking anywhere from 3 to 6 or 7 injections per day, depending on what kind of appetite they have. And so important things about dose timing. This was a wonderful question last year, and it's comparing insulin absorption and pharmacokinetics versus carbohydrate digestion. So what wins? So when we think about these two things, that is literally what they look like. And then unfortunately, carbohydrate metabolism wins because our insulins are not yet fast enough. And so when we look at that, there are numerous studies out there demonstrating this, and so this one actually had the nicest graph. So what we have here is blood glucose, and then over here time post-meal, and so the little diamond is if the individual took the injection 20 minutes before the meal, if they took it right at the beginning of the meal, or they took it after the meal. And so what's interesting is that both the timing at the start and after were actually pretty similar. They both achieved this right around, and ironically, it actually achieved it a little faster when you gave it after the meal. And then the ones given it before, though, really blunted that spike in blood sugar. So remember we talked about the complications, and we talked about A1C over time, and we talked about long-term and so on. Well, how many hours in school are these kids? How many hours are they there? It's a big part of their day. And so if we're blunting the peak, then that's having a substantial impact on their blood sugar control all day, for many years. Unfortunately, it's not really practical always to give it before the meal. How many of you can think to plan that far ahead in your daily routine? You can imagine an 8-year-old's not going to do that. So that's the best ideal, but we will do what we can, so I'm not implying that everybody has to give it before the meal. Analogs and pens basically are one and the same. Thankfully, most of the formulations now have insulin pens that make it a little bit more convenient to dose at school. So you just dial the dose, you screw a little needle on the top, and inject and go. Insulin pumps, mechanical devices, so they can have problems, but they have really revolutionized diabetes management, and studies have clearly demonstrated that the use of insulin pumps in the real-world setting is superior to every other management plan we have. When used in a strict research setting, it's pretty similar to multiple daily injections, but we know research and real life can be very different. Components, they sometimes will have a wireless remote control. Otherwise, they can also have a reservoir in the pump itself, and then a tube, depending on whether it's a patch pump or a tubed pump. We use fast-acting analogs for all the pumps. They have a basal continuous pulse of background insulin that can be actually programmed so it can go up and down, as opposed to Lantus or Levemir, the long-acting insulins where you just inject. These actually you can modulate it according to their need day by day. And then the boluses are for high blood sugars or when they eat carbohydrates. Disadvantage, you have to wear it all the time. You can detach it occasionally, but for the most part, it's on you all the time, and that's one of the things that the individuals don't like. However, head-to-head, like I mentioned, it is the most physiologic, it is the best. So ultimately, I would like all of our patients to be on insulin pumps. And just like the meters, there are many, so they come in a wide variety of shapes and sizes. As I mentioned, patch pumps, which just stick to your body and are controlled by a remote control, versus those that have tubes. You might say, why would a child or individual choose one or the other? Well, it depends on their lifestyle and what the pumps have to offer, because some are more sophisticated than others. These have to be switched out about every 3 days, 2 to 3 days. You just take them off, and then they have to, there's some devices that you can use where the family will just then inject a little needle through the skin, a little cannula is underneath there that for the most of the sets that you remove the needle, and then the only thing under the skin is a tiny, tiny little tube, a tiny little cannula that the insulin goes into the body. If a child has hyperglycemia and ketones, and they are nauseous, and they have a pump, what are you thinking? Right, something's wrong, okay? So it's most likely the pump. Now, whether it's because the pump has malfunctioned, or you ask the child when they changed it out last, and they say, well, last Thursday, and it's, Friday. So they've left it on too long, and the body will literally seal it off. So remember, anything that goes through the skin barrier is going to be an intruder, and so the body will eventually block it off. That's why you have to change it out so frequently. Now, the sensor that I showed you can literally stay on for 7 to 10 days, sometimes longer. And that's because it doesn't have a protein like insulin, it doesn't have a hormone going through the skin. Just threw this up here just to mention that all of the pumps have downloadable PDF menus, so for like a guidebook. So if you have a child who has a certain pump type, don't worry if you haven't seen that one before. You can get online and download that particular instruction manual. It's similar or much easier, frankly, than your cell phone. And so it may take a little bit of to understand it, but the menus are typically pretty easy. And then we can also walk you through those over the phone. So I just threw a couple up there just to show you the different ones. When we see the kids, I just wanted to give another example about what we look at all day long. And so this just is a download where it shows some statistical metrics for us. So values, 6.1 times they've checked per day that they've put into their system. Highest value in the 500s, lowest is a little bit hypoglycemic. How many values are above, below, or within target range. Particular areas that are of concern, and then we'll download the actual details so we can look at a particular time of the day. And so, for example, when they're at school at lunchtime, this is noon, I would say, okay, well, this child's on average a little bit too high, so I'd increase their basal rate from breakfast to lunch or change one of their ratios. So dietary treatment. Many kids and families will say, well, I can eat anything because I have a pump, because I take insulin and I count carbs. No. What we should be doing is eating a healthy diet, but we are Americans. And so sometimes we struggle with the concept of healthy diet. But if you decrease your concentrated sweets and sugars, all of us, then we're healthier. An individual with diabetes, remember I showed you how fast the blood sugar spikes? Remember that little graph actually was a set mixed meal that was given to 23 teenagers and adults. And so that was a mixed meal. It didn't include simple sugars. If it would have, that sugar spike would have been a lot higher. And so the insulin is just too slow to handle it. So what we tell our families is the occasional treat is perfectly acceptable. We want them to enjoy their lives, but having desserts and simple sugars every day is not, it's too challenging for the insulin. So how do we dose insulin? We use a glucose correction factor. The pumps will often call it an insulin sensitivity factor. So all that is an estimation of the amount of blood sugar that will be reduced by 1 unit of insulin. So it could be 1 for every 50, for every 100, for every 25. And so you check your blood sugar. And so here, for example, correction factor would be 1 for every 50. And so if the glucose was 250 and the target was 100, that would be 3 extra units that that individual would give to make their blood sugar drop down. For carbohydrate counting, you look at the meal. That one's kind of scary. I've kept that in my slide deck for ages because I just find it humorous. So the insulin to carb ratio is the number of grams that 1 unit of insulin will cover. Remember, that's sort of a standard. So an apple is different than Papa John's, is different than pasta, is different than bread, and so on. So all those are different. And so unfortunately, to do a real insulin to carb ratio, we'd have to assign it according to what type of carbohydrate. Well, we can't do that. That's too complicated. So we just do a flat rate. It can change throughout the day, though, depending on the needs of the individual. But for this example, 1 unit will cover 15 grams. And so if an individual is eating 60 grams, be 4 units. All right, so support and planning. Just a little quote from Eleanor Roosevelt. So our role as in support of the child is to build trust so that both the child and the parent or caregiver can feel good about their child being out of their direct line of sight, which many parents have trouble with. It's to reduce the fear that the child will struggle or have something bad happen to them when they're at school or on the playground or at a sporting event. Build hope that they can live a typical life, happy, healthy, active lifestyle. And so we provide the medical needs, sometimes additional financial support. And then the real deal is that we want to empower every single child, young adult, and adult with type 1 diabetes to feel like they have everything they need to thrive. So when we develop a school plan, it requires a lot of people. The most important are those who are actually the advocates at the school that are caring for the child. Public health nurses, school nurses, office personnel, and teachers. You need all these individuals. At home, the main advocates, of course, are the parents and the siblings. And those individuals who are usually untrained, they're not medical personnel, those are the ones that are actually providing medical care and doing everything that they expect the school to be able to do. Cafeteria personnel, I also don't want to forget them. They're highly important too. So impact of diabetes on performance, that's why I put that other slide earlier. I just wanted to make sure we understood that very high blood sugars or low blood sugars can affect a child's ability to perform well. We want to look at a 504. Everybody familiar with 504 plans? Okay, I know, it's yes. So House Bill 98. So really what this does is this designate what are the responsibilities of all those involved. It's very important to engage these people, okay? Because a lot of times they will want all of the responsibility on here or up here. No. So we got to make sure that they are an integral part of, and they know what their responsibilities are in making sure that that every day goes as smoothly as possible. Communication lines are very important as well, and so that means that identifying which individuals at the school are allowed to communicate with the healthcare team. And so there have been problems in the past where certain ones were designated, and then this teacher or this vice principal is the one attempting to contact our office, and we're not allowed to communicate with them. So we want to make sure that everybody involved is listed and designated by the parents as to keep that free of trouble. School care, the care forms we update constantly. So if you see one that doesn't seem to match up with what the child is doing, notify us, because then we need to update it. Families will modify insulin plans at home when they see a problem. Sometimes they won't bother to communicate with us. And so if you see a variance there, they claim that they've changed something, make sure you get the updated form so everybody is protected. Be flexible. That's kind of creepy, that picture. But the deal is that not every situation conforms to the forms we have. And so just understand that we couldn't create a form that literally had every single scenario. You know, a meteor hits the school and the child drops their meter into an alligator's mouth or whatever it might be. So we try to maintain order out of chaos, and then if you get concerned, call the office. So we are always happy to help. And we continue to add personnel too to continue to serve your needs. So blood glucose monitoring, this little cartoon says, I'm the blood sugar fairy. If you can see me, yours is too low. So the ideal, I keep talking about ideal, is to have the meter on the child's person or in the room with them. Because if the office is far away and they complain that they don't feel well, like they're low, it's a bad idea to have them walk to the office, because they can collapse or fall down the stairs or have a seizure or something terrible could happen. Best to have it in the room. The other thing, whenever possible, and this is not always possible, whenever possible, try to make it as easy as possible for the child to check their blood sugars. Why? Because when they are singled out as being incredibly different, they already feel so different than the average child. Singling them out makes it so much worse. And so as they get older, they will find ways to avoid checking, and then the next thing you know, they're a 14-year-old with an A1C of 12%. Okay, so we've got to try our best to make it so that they feel comfortable with all of the burden of diabetes. And so before meals, before after pee sometimes, and then it's helpful before a bus ride. And so again, we try to say no concentrated sweets, although we really know that that's not a complete reality. Carb counting, so it's great when the parents can pack the lunch and write it on the bag. We encourage that, but most of the time the school lunches are what the kids eat at. So we have to work very carefully with the school personnel, the cafeteria personnel, in order to make sure we're on top of things. All right, so ending with school management, and these are just a few scenarios. Updated them a little bit, but similar to last year, to provide an example of all three management types. So this is a meal in the life of little Jay. He's a 6-year-old boy in school. Mommy gave him a mixed dose of NPH and Humalog. You might not see this much anymore, actually. He has a bag lunch with 52 grams. He's supposed to only eat around 45. And so remember, that's the plan. So you have the mixed insulin dose at breakfast, mixed at dinner time. So he checks his blood sugar and it's 212. Well, what do you all do? Well, you don't do anything because the NPH is still peaking, and so you just have to assume that it will be covered by that, the meal will be covered by that. So you record the blood sugar and send him to lunch. Let's jump out with a little, because unfortunately life is not so easy. So he has an upper respiratory infection, and he says, I feel fine, I feel good. So he has his bag lunch, but he checks his blood sugar and it's 312. Uh-oh, trouble. So what do we do now? And so that really depends on his school plan. So we're limited to the school plan. That's why we have to realize that we might have to go outside of the plan and communicate with our office and get additional verbal orders. But we record the blood sugar. Likely it has something in there about checking for ketones if it's above a certain glucose value. So what if he has small ketones? And so his plan might allow for an additional injection of Humalog to help with that. If it doesn't, it may require a contact to the parents or to our office. All right, Brett, good looking devil. So 15-year-old boy on a multiple daily injection plan, looks at his bagged lunch, and he's going to eat 62 grams. His insulin to carb ratio is 1 to 15, and so he's eating 62, so that would be roughly 4 units, right? So that's what it calculates out. He checks his glucose, 242, and you say, why is it 242? And he says, oh. And he doesn't, did you eat anything? Maybe. His correction factor is 1 to 50, and so what you do is you calculate that out. That comes out to be about 3 units, and so in effect you give him 7, right? Or he takes 7. So record the blood sugar, attach, if he has a new pen needle. Some of these kids, you'll ask, when did you change that last? And they'll say last month, and it's like 25 days they've had it on the same pen. And then visually monitor the injection. At that point it's like, won't go in. And so then you can go ahead and send him to lunch. Oh no, there's another pop quiz. So what if he says he's not hungry? Now, how many times have you heard a 15-year-old boy say he's not hungry? So I know this is not realistic. But he's going to say, I'm not eating. So he might have looked at the menu and it's like liverwurst and onions or something like that. And so his blood sugar is 242. What do? His correction's 1 to 50. So what you do is his total insulin dose is just 3 units. And so you just record the blood sugar, monitor the injection, and send him on his way. Now, one important fact that I failed to mention is the kids will, remember, they try to get out of doing these things because if you haven't checked your blood sugar before, it hurts. And so now if you've done it thousands of times, eventually they'll have callus formation and it doesn't hurt so much on those little areas. But it does hurt and it's time consuming, and kids don't like spending more than 1.3 seconds on any activity unless it's a game, video game apparently. And so they will do this deal. What's your blood sugar? It's 182. And so make sure that you either saw them do it and then you look at the time and the date on the meter, because kids are very clever. So, and you can understand. I mean, they're kids. They have no real understanding of what this means to their health. So they will try to get out of, they'll cut corners every time. So just make sure you're alert. And don't let them, I'm going to go to the bathroom to check my blood sugar and give my insulin, when you're the only one in the room. You should make them do it right then, okay, right in front of you. And then if he eats, which he will, just tell him to come back. Actually, he won't come back, and then the mom will complain about your performance and everybody gets upset. So then we download the meter and then we talk with mom and we settle it. But anyway, just terrified you there. But most of the boys and girls are actually pretty good about making sure they do everything they need to do. So this is Hallie, 15-year-old on an insulin pump. Of course, it's fancy, so she has to have everything that's fancy. She looks at her menu and decides to eat 62 grams, just like Brett. But her insulin to carb ratio is 1 to 12, and her pump will give her 5.15 units. There's some pumps that go out to the thousandth. So we're getting closer and closer to some impressive capabilities. Her glucose is 182, and her correction is 1 to 35 at that time of the day, because it modulates throughout the day. So the total blood sugar, or total insulin dose, is 7.5. So you just watch her do it, make sure she types everything in correctly, and you're essentially just an observer. And so send her to lunch. And there's, of course, has to be a curve. So I'm not sure why this shrunk on me, but she's complaining of nausea and belly pain when she comes to you, and her glucose is 582. And again, what's going on? Pump, you got it. So the pump is probably not working, or there's an occlusion of the, so it might not be malfunctioning, it just might be the insulin's not getting to the individual, to the child. So you record the blood sugar, you check urine ketones, they're large, we contact mom, because you haven't even seen dad before and you're not even sure if he even realizes that his daughter has diabetes. I'm selling guys short. There are guys that bring their kids to the diabetes center. So I shouldn't do that either because I'm male. So anyway, so you discuss giving a sub-Q injection with a syringe or a pen with the diabetes educator, provider, or the parent. That might be in the plan, in the 504 plan, in your management plan. And because you now think that the pump, rightly so, is not working. So you could leave it in, it doesn't really matter at this point, but we'd want to give insulin by some other mechanism. And so that usually requires the parents to get involved. We have talked about switching pump sites out and so on in the school. Largely we think that's a bad idea because that creates an even larger burden. This child at this moment is likely in DKA. So you do not want to, we'd want to get them seen and treated, and so they need to be heading out to probably the emergency room. All right, last few minutes on type 2 diabetes. Hopefully I haven't talked too fast. This little cartoon says, my doctor says I am a type 8 diabetic. That's a type 2 with 4 times more excuses for not exercising. And you're thinking, oh, type 2 in children, that doesn't happen. Well, I've talked about this for several years. When I first started out, it was less than 1% of our patient population. Now it's closing in on about 7 to 8% of our patient population, which is pretty frightening. So a lot of different causes. It has a stronger inheritance pattern than type 1 diabetes. But lifestyle plays a very strong role in, particularly in children. So you have the same types of symptoms, but you might not think diabetes because the child is obese or overweight. All children with type 2 diabetes will be overweight or obese. That's 100% of them. They typically will have acanthosis nigricans. That's this black, darkened, velvety appearance to the skin, regardless of race or ethnic background. It's usually around the neck, the axilla, the antecubital fossa, it can be the fingers, and that is a response of the skin to high insulin levels. Family history. Now, one thing I mentioned about the overweight or obese, now about 30% of our children with type 1 diabetes are overweight or obese. And so that was unheard of in the 80s and before. Now it's very difficult to distinguish, and so we do a lot of testing in order to identify what form of diabetes the children have. All right, the treatment, eat less and exercise more. That's the most ridiculous fad diet I've ever heard of, or I've heard yet. Treatment, as you can imagine, it's really focused on lifestyle modification, which for any human is incredibly difficult no matter who you are. So nutrition, dietary counseling, exercise counseling, glucose monitoring, and medication therapy. The glucose monitoring can be as little as a few times a week, and that's it, all the way to the same as someone with type 1 diabetes because they take multiple daily injections. There are a number of different, there are many different treatments for type 2 on the market. However, almost all of those are for adults. And so as studies continue, which we're an active research center, we hope that those will be available. But for now, metformin and insulin therapy are the two main ones. And that is it. And so our clinical support, we now have 5 diabetes educators, several who are nurse practitioners, or several who are nutritionists. We have 5 endocrinologists, 1 diabetes psychologist, and our group continues to grow. We see kids every single day of the weekday. In the weekdays, we have a doctor on call 24 hours a day, and we see kids in the office from about 8 o'clock to about 5 o'clock, but our educators are available around 9 to 5. And that is our group.